Good afternoon, everyone. Welcome to Grand Rounds. We have a nice group in the audience. Thanks, everyone, for making the effort to come over and join us. And for a treat today, Dr. Nora Vish is going to be talking about the science of resilience. So it's going to be a great lecture. For those of you on Teams, just a friendly reminder, when you join us, make sure you don't hit mute all, because that mutes the speaker. Go ahead and mute yourselves, because otherwise we'll hear everything you're saying. But don't hit mute all, please. All right, I'm going to turn it over to Dr. Matson, and he is going to be doing the introduction for Dr. Vish. All right, everyone, thanks again for tuning in.
All right, hello friends and colleagues, and welcome back to Grand Rounds. Today we will be hearing from Dr. Nora Vish. A little bit of her backstory. After graduating from the University of Michigan, Dr. Vish received her master's in public health from Yale University. There she started her journey to improve health of marginalized populations, specifically studying parasitic infection in South American populations within our impoverished communities. She completed medical school at Wayne State University and went on to complete her pediatric residency at Northwestern University at Children's Memorial Hospital.
Message at the tone.
As a
When you are finished,
pediatrician,
hang up or press pound for more options.
Okay. Is anyone else hearing that? Was that just me? Okay, good. Sorry, sometimes the voices in my head make it out. All right, I apologize. At least they were speaking in English this time. Sometimes it's in Spanish, and that's fun for me. Helps me keep my Spanish up. Back to Dr. Vish. As a pediatrician, she has provided a wide spectrum of care from working in our emergency department, as a hospitalist, and as a primary care pediatrician. At Dayton Children, she has focused her efforts in providing care for children residing in foster care. In all areas, she strives to improve the health and well-being of underserved and disadvantaged children through practice, research, teaching, and community health involvement. Speaking of research, her interests aim to bring to the forefront issues such as food trauma, resilience, food insecurity, and poverty to healthcare of children. Ladies and gentlemen, please give a warm welcome to Dr. Nora Vish.
Thank you to everyone's here, and thank you for listening to me talk about resilience, and I'm happy to see so many friendly known faces in the audience. So just starting, this talk is the science of resilience, moving from trauma and illness to resilience and well-being. And so the question is why do some children who experience trauma seem to have no long-term consequences? In my line of practice, I treat children who have faced significant adversity, often facing parental drug addiction, parental mental health struggles, they themselves having faced physical abuse, sexual abuse, emotional abuse. And children in foster care, as we know, have often negative long-term life outcomes. They have higher rates of incarceration, higher rates of homelessness, lower rates of high school graduation. And yet, despite all of this, some children seem to do great. And why is that? And the answer really is resilience. So that is what I want to spend this talk discussing. So kind of a little bit of a roadmap of this presentation. To discuss resilience, you first need to discuss a little bit about adversity and what's known about adversity. Just as a by the way, in this talk, I'm going to be using the word adversity primarily, but sometimes you're going to hear me use the word trauma, and sometimes you're going to hear me use the word stress. So just know these are all interchangeable words. Next, I'm going to go to resilience. When it comes to resilience, I really want to pull back the shroud of mystery around the word resilience. I want it to be known as a well-defined, measurable, medical, something that we can advance medically. Next, I'm going to talk a little bit about the neurobiology of resilience and a little bit about what's been learned about this science. Some of this happening through modifications of key hormones of how we handle stress, how we handle trauma, and how we handle resilience. So I'm going to specifically kind of highlight cortisol and dopamine. Next, I'm going to talk about some studies and resilience and healthy outcomes. So to first understand adversity. Adversity came to the forefront of medicine in the late 1990s with this giant study that was done between the Center for Disease Control and Kaiser Permanente. And this study was took 17,000 middle-class, white, insured population, and the results were kind of stunning. They found that as the amount of adversity increased, so did the adverse health outcomes. So not only was there increased risk of behaviors associated with negative health outcomes, such as smoking, severe obesity, depression, and suicidal attempts, but there was also increased risk of ischemic heart disease, cancer, stroke, chronic emphysema, and diabetes. So how did this study measure adversity? This study measured adversity kind of going through and classifying adversity into three main groups. So abuse, neglect, and household dysfunction. Abuse, physical abuse, emotional abuse, sexual abuse, neglect, physical and emotional neglect, and household dysfunction such as parental incarceration, parental mental illness, parental drug addiction, domestic violence in the home, and they did classify divorce. So there's 10 here total. And so people had a score of 0 to 10. 0 that they had faced zero adversity, 10 they had all adverse events in their life. This study subsequently has been repeated at least hundreds of times. It's been repeated in different populations. It's been repeated with different health outcomes. Even within pediatrics and pediatric health outcomes, this study is reproducible. Oh, no.
No, sorry about that. They can't see or hear yet, so we're just...
Sorry. All right. Should I keep going or? Okay, so this study has been repeated hundreds of times at least. And so within the pediatric population, pediatric health outcomes, it's also been repeated. And again, you can see kind of a bit of a dose-dependent response. So the increased adversity in children, you see increased rates of negative health outcomes. These are two recently published studies. The first one is on pediatric asthma, and as the number of adversities children face, so does the risk of them having asthma. This first study does control for race, family income, prematurity, smoking in the family, family education, and neighborhood safety. And more recently, the study done just a few months ago published in pediatric seizures. And again, a dose-dependent response on risk of pediatric seizures to the risk of to adversity somebody has experienced. And this has also been done with other health outcomes such as diabetes, obesity, substance abuse, suicide, and other mental health problems. So this really is key to our pediatric practice. So here are the initial 3 categories of adverse childhood events from that initial study in the late 1990s. We can see they're classified as family dysfunction, abuse, and neglect. But since then, other adversities really has come to the forefront. Things like food insecurity and the effect of food insecurity, the effect of poverty, prenatal factors such as prenatal stress, prenatal depression, homelessness. How about historical or racial trauma and race as an ACE? How about community violence? So all of these affect the balance of health in our population. So how do we define resilience? What is resilience? So using the definition of a process of healthy adaptation after adversity. So first of all, there must be some degree of adversity. There must be some degree of threat to the person. And after that, there has to be healthy adaptation. You don't have the negative health outcomes. And lastly, it's a process. So it is dynamic, it is reversible. Resilience is something that can be built. And I hope that at the end of this talk, that is one takeaway that you firmly have, is that resilience is a buildable process. So resilience is also multidimensional. It has intrinsic components within a person, within a child, and their ability to handle and recover from negative experiences. But there's also a lot of extrinsic factors, factors within the family, factors within the community, and also friends. So how do these things contribute also? What is resilience not? It is not an absence of pathophysiology. It's not an absence of dysfunction, but it is its own entity. So we know here in the balance of health is all the risk factors, but how about these protective factors that we kind of discussed in resilience? So individual resilience, but there's also caregiver resilience. In foster care medicine, we often say that it just takes one consistent, compassionate, available caregiver to change the outcomes of one child. So that caregiver resilience and that important relationship. Community resilience, how does the community rally around children and people? And family resilience. I'll go into far more depth in these in just a bit, but these also affect the balance of health. So how is resilience measured? How do you get this construct, this vague idea of process of healthy adaptation after adversity and measure it? So you can see that there's a lot of resiliency scales out there. There's quite a lot of them. And there's no one particular gold standard when it comes to a resiliency scale. And they're all, series of questionnaires the same way that we do. We diagnose many mental health illnesses is by a series of questionnaires and seeing how people respond. But I'm going to go through some of these in depth just to kind of highlight some of the differences and some important things about resilience. Okay. Nope. Okay. So first I'm going to highlight, this is one of the earliest definition measures of resilience, and this is called the Connor-Davidson resiliency scale. And it measures the ability of a personal resilience, of individual resilience. So a person's ability to adapt to change, deal with what comes along, cope with stress, stay focused and think clearly, not get discouraged in the face of failure, and to handle unpleasant emotions such as anger or frustration. One thing that you can see with this is that it's really a personal measure. It's really an individual measure of resilience. This was first published actually 20 years ago in 2003. And so therefore, it's the most validated. It is the most reliable resiliency scale that's been out there. But like I said, one of the things that it lacks is that it doesn't have that multidimensional component in it. When this first was published, I went back and looked at that article from 2003. It was interesting because it was done with a psychiatry group, and it took patients that were receiving treatment for anxiety, depression, and PTSD. And they found that people who had significant improvement in their clinical illness also had an improvement in the resiliency score as it was treated. And conversely, the opposite was true also, that people that had no improvement or even a deterioration in their treatment of either anxiety, depression, or PTSD, that those people had minimal or no improvement at all in the resiliency score. So right from the beginning, being defined as something that is dynamic and something that really correlates strongly with health. So moving to other resiliency measures that are more multidimensional and look at resiliency in a global way, you can see there's the Mastin's multi-system that looks at individual resilience, again, like that Connor-Davidson scale. It also looks at family resilience. How does a family work through problems? How does a family stay hopeful? How does a family rely on their own personal strengths? Looks at supports outside of the family, such as community, school, religious supports. So that's the Mastin multi-system. The other one I want to highlight is called the Resiliency Portfolio Model, because it also looks at those individual regulatory skills, looks at those interpersonal skills, the skills that are given within schools, within communities, within religious structures, anywhere that a child is frequently, but also looks at something interesting called meaning-making strengths. And that is how a person reframes adversity, how a person makes sense of what they're going through, In life, sometimes there aren't problems to be fixed. Sometimes it is simply the way it is. But how somebody looks at the problem and finds meaning in that problem really to be a significant thing. And I'll come back to this later on. So this comes from the National Survey of Children's Health, and I like it because it's a bit short. And this is family resilience. So when a family faces problems, how likely are they to do the following? How likely are they to talk together about what to do, to work together, to know that they have strengths to rely on, or stay hopeful even difficult times? And again, measuring community resilience, asking how often people in neighborhoods help each other out, how often do they watch out for each other's children, or how often do people in a community know where to go to for help. So when we start talking about resilience, initially it was believed that resilience and adversity were really strongly linked to health behaviors. So you can see how somebody coping with adversity might have maladaptive behaviors such as substance abuse, overeating, or even promiscuity that would result in negative health outcomes. So this behavior links, so self-destructive high-risk behaviors versus the ability to walk away from high-risk behaviors and that to maintain that clear and positive attitude. Increasingly, though, we're realizing that there really is a strong neurodevelopmental disruption, that there's actually a change in brain anatomy that occurs when you face adversity and when you face resilience. And so much more exciting is this epigenetics field that is coming out, and the stuff coming out through that is amazing. So epigenetics is a change in the expression of one's DNA that is modifiable based on our experiences, and how what is translated really has to do with how we experience our world. And one thing, again, about epigenetics, it is dynamic and it is reversible. So the way we change our genes is dynamic and reversible. But of note, sometimes it can persist throughout life, and sometimes it can persist through the next generation, unless there's a change that happens. We'll talk a little bit more about that. So you can't really talk about how a person processes emotions, how we process threats to ourselves without really talking about the limbic system. So just a little bit about the anatomy of the limbic system, so we all have a unified vocabulary here. There's the amygdala, which is in the center of the brain. It's like an almond shape brain structure that is the fear processing center. There's the hypothalamus. The hypothalamus is a big regulator of how we handle threats. The thalamus, which is the relay center of the brain, and the hippocampus, which is important in terms of converting short-term memories into long-term memories. I'm going to spend some time speaking of this hypothalamus, because the hypothalamus is coming out as a big regulator of how we process emotions, and the hypothalamus is key in terms of epigenetics and how epigenetics works. So we talked a little bit about how adversity affects the structure of the brain, the anatomy of the brain. So some early studies done with soldiers coming back from war with PTSD, comparing those to soldiers that didn't have PTSD. And there are studies that show that individuals that have suffered significant adversity and have PTSD have smaller amygdala volumes, smaller hippocampal volumes, and have decreased connectivity to that prefrontal cortex, which is that decision-making part of the brain. There's also been functional MRI studies showing that individuals with PTSD have exaggerated amygdala responses to emotional stimuli, and they have exaggerated glucocorticoid responses. And this all results in kind of an increased fear conditioning, hypervigilance, and reactivity. This study has also been done not just in soldiers coming back from war with PTSD, but also in children with having experienced significant adversity. And in the bottom of all my slides, I try to kind of refer to the study that I'm talking about. Sorry. So epigenetics. There was a time that we believed that our genes were simply the book that was read the entire the entire way through and always read the same way. And increasingly, we're realizing that's not the case, that epigenetics really determines what is read within our genome. So you can say that we're not our genome, we're actually our epigenome. And epigenetics comes from, so this is a picture of histones. And histones really, how tightly wrapped the DNA is around a histone determines part of what is read in terms of our DNA structure. And there's specific processes, two of which are methylation and acetylation, that acts to either activate gene transcription in terms of acetylation, or methylation kind of silences that gene transcription. Again, I'm going to be using some of these words later, so just for common vocabulary. So talking a little bit about how people handle stress. So one of the main ways that we all handle stress is through this hypothalamic pituitary adrenal axis. And of course, when we are faced with an acute stressor, we need to have a rapid, well-coordinated response to the stressor, and it has to be both physical and psychological. We really can't stop and ponder what our reaction to the tiger is going to be. So hypothalamic pituitary adrenal axis. So first we start off with that stressor, that threat to the person, and then the hypothalamus responds with the release of corticotropin releasing factor and AVP. The pituitary then releases ACTH, which causes the adrenal glands to release cortisol. Now, of course, the body doesn't just turn on, it also has to turn off. And this turning off mechanism is key. So stress ultimately resulting in an increase in cortisol, but there is this negative feedback loop, and that negative feedback loop occurs through that glucocorticoid receptor, which is in the hippocampus. And that negative feedback loop, you can think of it as the body's on-off mechanism. So the threat and the stressor turns on the HPA axis, and the glucocorticoid receptor turns off our stress response. And epigenetics, I'm going to go through some studies that kind of show how epigenetics really acts on the expression of this glucocorticoid receptor, and thus dampens that stress response. So we know that adversity turns off the expression of this glucocorticoid receptor, and thus turning it off leaves on the stress response. So it silences that negative feedback loop. So we therefore feel a sustained exposure to high levels of cortisol. That sustained exposure to high levels of cortisol having these negative long-term health outcomes, such as hypertension, immunosuppression, cardiovascular disease, and other health problems. But let's move to resilience again. I want to spend time speaking not just on the effects of adversity, but the effects of resilience. So what are the effects of positive stress on epigenetics? Moving the conversation to letting your children fall and teaching them to pick themselves back up again, and avoiding a learned helplessness. So as we know, not all trauma is negative, not all stress is negative, but there are things like positive stress. So we all remember failing our first test, and therefore we learned that we need to study more than the night before. Some of us remember losing a key game and feeling the community or your family rally around you. And so we remember how stress acted in our lives positively. And when we talk about stress too, stress is modified by not all stressors are equal. There's the type of stress, the severity or the intensity of stress that we have, the duration, the chronicity of stress, the timing, when in a child's life does it occur, and more importantly is the effect of the stressor. Do people feel that they can create change from this stressor? Can they change their own life or change the life of others from the stressor? Or do people feel stuck in a loop of being powerless or helpless? So talking about studies of epigenetics of resilience. This is an interesting study done on mice, and I'm sorry, the picture of cats, but it's significantly cuter. So in mice mamas, a mice mama shows high maternal care by lots of licking and lots of back arching. So that is a high maternal care mouse. And so we know that mice that have high maternal care have increase of this glucocorticoid receptor expression. They have increased of that negative feedback loop that turns off our stress response. And that negative feedback sensitivity therefore dampens the stress response. So in mice that have been exposed to high maternal care, we know that they have less anxiety, less fear conditioning, and overall less of this hypothalamic stress responsivity. And more importantly, that this dampened stress response persists into adulthood with these mice. That the adult offspring of mice with high maternal care are better able to modulate their stress response, and that this is happening through glucocorticoid receptors. And there's also reduced plasma ACTH corticosteroid response to acute stressors. And so, some translational studies that were done. Of course, we're not mice. In terms of populations, we know that have gone through significant adversity. This study was also done, not completely the same, but done in children in foster care. As we know, children in foster care have gone through significant adversity, and it was shown that they also have blunted patterns of cortisol production across the day. Normally, we should wake up with high levels of cortisol, and that level of cortisol kind of decreases throughout the day to kind of a very low level before bedtime. And that this blunted cortisol response was also associated with kind of conduct disorders, antisocial personality disorder, and substance use. Another study that was done took children that were CPS involved and had two different groups. The ones that were CPS involved and stayed with their family of origin as the family of origin worked through their problems, and others that were placed into foster care. And the ones that stayed with their families of origin did have a more blunted pattern of cortisol production. And there was also a comparison group of children that weren't involved in CPS at all. And the children that stayed with their families of origins had significantly higher cortisol levels at bedtime. Another study that was done is it's not just being placed into a place where there's less adversity, but also the type of care that we receive. Whether this is kind of nurturing, highly responsive care, or is this kind of less nurturing, less responsive. So this is another study that took children that entered the foster care system and did video interactions of the foster child and the foster family, and kind of classified families into either highly responsive, meaning that they had sensitive care, followed the child's lead. They had lots of positive expressions in their interactions. They showed lots of enjoyment, lots of a warm tone of voice. And what they found was that sensitive foster parents had foster children with healthier patterns of cortisol release. So so there's a lot of plasticity to the how we respond to stress and stressors. This is another translational study which kind of took breastfeeding as a proxy of that high maternal care and high nurturing. And so they took children that were either breastfed and not breastfed, and they exposed them to a stressor. And now in infants, one of the biggest stressors that you can have is called the still face experiment. And for those that you don't know, the still face experiment is usually when somebody interacts with a baby, they're very responsive. When the baby smiles, we smile. When the baby points, we look. When the baby shows joy, we show joy. When the baby shows distress, we show distress. But the still face is just kind of like a blank face. It's non-responsive to the child's clues. And this is very well known to release higher levels of cortisol and produce distress in infants. So amongst these two different groups, they found that children that were breastfed had better recovery from this still face experiment than children that were not breastfed. There was, again, this is occurring through that DNA methylation of the glucose. This is probably more science than I want to go into, but resulting in enhanced glucocorticoid receptor expression. That increased glucocorticoid receptor expression having that better negative feedback loop to the cortisol release, and overall showing decreased stress reactivity. Of note, I mean, there's other ways besides breastfeeding that you can have high maternal care. And I think it really is that act of holding while we feed, loving, and those, like, you know, every 3 hours, 20 minutes of intense bonding. So we know that resilience buffers our cortisol stress response. We know that it does this through this negative feedback system and decreased methylation, which therefore increases glucocorticoid receptor expression, and this negative feedback loop that occurs that overall improves our stress reactivity. We know that infancy and adolescence are times of high neuroplasticity. So as pediatricians, we're working with infants and adolescents quite often. So this is something that we have a role in building. And this is a dynamic process between the brain and the environment. So again, resilience known to buffer our stress response through that glucocorticoid receptor and turn off our cortisol stress response. Quickly going through another mechanism that our bodies respond through epigenetics to stressors. One of those is dopamine. And this is Joy from Inside Out. So you can think of Joy as dopamine. She's our feel-good hormone. This is the hormone we want more of in our brain. Dopamine is really important in learning, in feeling reward from our activities, feeling reward from our experiences, control of emotional behaviors, executive functioning, cognition. And it also has its regulatory mechanisms. So there is the dopamine receptor that when you bind dopamine to the dopamine receptor, you have that pleasure response. And it has also its own negative feedback loop, and that's called DARP32. So epigenetics working on these regulators of dopamine. So stressed mice. So the initial study was done that took 3 groups of mice. So they took mice that had long-term separation from their mamas. They took mice that had short-term separation from their mamas. They were just removed from their mom short-term and then put back with their mom. And then they had a control group with no separation at all. And all of this showed that there was epigenetic changes in our dopaminergic pathways, and that these changes persisted into adulthood and affected our stress response. And interesting, the long-term separation mice had the opposite result as the short-term separation. So in the short-term separation, we see that there's increased expression of the dopamine receptor. There is decreased expression of that regulator or off mechanism. And not only that, but again, this persisted into adulthood. So the ones that were short-term separation from their moms had improved response to, they did a forced swim test. So in the ones that had short-term separation from the mom, they performed significantly better in that forced swim test than the ones on the other extreme, the long-term separation, and kind of in the middle was the no separation. And again, this was done showing that there's that long-term stress increased that DARP32 expression, where short-term stress decreased that DARP32 expression, both having kind of like opposite effects in how we handle stress. So this picture is from Inside Out, and this picture is kind of like the family working together to work through a significant problem, and kind of relying on their strengths, relying on talking through the problem. And so this is a picture of family resilience here. So through these animal studies, through these translational studies of children who have been in foster care, children with high nurturing, and mice studies, we know that short-term stress results in better stress coping and resilience later in life. That it promotes flexibility, that and with that is adaptation of behavioral strategies to changing environments. And doing so through some key hormones such as cortisol and dopamine. There's a lot of other hormones that have been studied and endless studies talking about the epigenetics of this. It's a bit of a rabbit hole when you go down. There are studies about the regulation of norepinephrine, again, key to our fight, flight, or freeze response. Our serotonin regulation, neuropeptide Y, which counters that cortisol response, oxytocin, how we attenuating fear responses and kind of bonding. And lots of studies talking about how our immune system is regulated through our stressors or through resilience. Again, I'm not going to go through all of this, but just to kind of show that there's a lot of science behind our regulation of stressors and how our experience affects how we show our genes, how we express our genes, and therefore our life experiences. So overall, does resilience affect health? So this was a recently published in Current Opinions of Psychiatry and took a literature review of resiliency studies. And they took children exposed to different types of threats or traumas, children exposed to war, natural disasters such as hurricanes, tornadoes, or in children with high levels of adverse childhood events. In all of these studies, unanimously, all the children with higher levels of resilience had fewer symptoms of depression, anxiety, and trauma symptoms. This is a study that looked at community resilience. So defining community resilience as willingness to help each other out, intervene when a problem arises, positive adult role models, and wanting to help each other's children out. In resilient neighborhoods, let me back up. First of all, once again, it showed that children with higher levels of adversity had higher levels of anxiety, depression, conduct disorder, and suicidal ideation. And once again, it showed that this was in a dose-dependent response. So adversity equals poor health outcomes, except in high resilient neighborhoods. Because in high resilient neighborhoods, these negative health outcomes were modified. They weren't seen, which is, I think, kind of important. And this study also controlled for mental health at baseline, depression of the primary caregiver, neighborhood safety, sex, ethnicity, and family structure. This was done in Canada with 5,000 adolescents in different communities. Another study showing that resilience affects long-term health outcomes. Again, this published in Journal of Childhood, Adolescent, and Trauma, 2021. Again, there's a dose-dependent response, and the more ACEs a child experiences, there is more psychopathology. But again, resilience buffering the impact of ACEs. And it did use that original ACE questionnaire as a measure of resilience. It used a multidimensional measure, which looked at individual relationship, communal, and cultural. So resilience buffers the negative health effects of adversity. Shifting a little bit to cultural humility. So cultural humility is the recognition that not everybody faces the world as one does, that our experiences, our family experiences changes our perception of the world and how the world treats us. And so cultural humility is kind of being open to learning to others. And there's an element of cultural humility in when we're talking about adversity and when we're talking about resilience. So resilience may be different in different communities, and to study resilience, you have to be open to learning how a community faces adversity. And so this was a study that I liked. So this one was done in a rural, impoverished community of Appalachia. And using the resiliency portfolio model, which looks at that meaning making, showed that a concept called enduring strength was really, really a buffering factor to how adversity affected health and well-being. And enduring strength is different than grit, but similar to grit. So grit is kind of persevering through adversity, but it tends to be kind of very goal-oriented, as opposed to enduring strength really had a sense of staying true to oneself and staying strong for the family in times of adversity. So it was really a process. And so in rural Appalachia, enduring strength is kind of a meaning-making resiliency factor that really buffers how adversity affects health. So individuals that had high scores of enduring strength had improved mental health after adversity and higher overall physical health. So how can we promote resilience? One of the things I like best about resilience is in medicine, children come with the traumas that they've experienced. It's very difficult to go back in time and erase that trauma, but we can build resilience. We can build resilience, and sometimes, especially with children, it's easier to build resilience amongst families and amongst the community, and eventually with the child themselves. So there are caregiver and family-based interventions, one of which is, again, in foster care children. It's called the multidimensional treatment foster care for preschoolers that works to bolster supportive caregiving. We know the type of caregiving a child receives after adversity is important for how they develop resilience, and overall improves attachment and regulatory skills. There's community-based interventions. And I want to highlight one that we have right here at Dayton Children's Hospital with our student resiliency coordinators. So Sue Freilich, thank you for being here. She works with the student resiliency coordinators, and they work with adolescents that are identified to be at high risk, and children as young as the age of 4, identified to be at high risk. And they work to build resiliency skills within that child, but not just within the child, but also working closely with the family with that ultimate goal of having the family know how to work through problems, how to rely on their strengths, know where to go in the community for support. And this is a study that we published on looking at resilience and health outcomes, and showed that children with less resilience in this population had, for each standard deviation in resiliency measure, the risk of mental health ED visit increased by 1.4. How about in our medical care? How about in our clinics? How do we build resiliency in our clinics? This is a study I published with a med student who's now an internal medicine intern, looking at family and neighborhood resilience. And it showed that families that are identified as high resilience were 60% more likely to receive care in a medical home. And families that were identified as moderate resilience were 30% more likely to receive care in medical home. And it may be that resilient families seek out that medical home, but alternatively, it may be that medical homes work to build resiliency in our families. And if you remember, medical homes are defined as kind of a team-based, patient-centered approach that works in a coordinated and meaningful manner, and really works to establish a relationship of mutual trust and mutual responsibility. So it's really the importance of process. And medical homes work with a lot of wraparound services. In our medical home at Dayton Children's Pediatrics, we have care coordinators, we have integrated behavioral health, we have community health workers, we have healthy steps to work on that maternal-infant bonding. So all of these things are kind of important in building resiliency and teaching families to become more resilient, and therefore kind of buffer the effects of adversity within our families. So what is the role of resilience in our clinical care? We know if adversity affects health. We know resilience affects health. We know that this is a dynamic process that can be built. We know this resilience is measurable. Maybe we should measure resilience. Right there, we measure our family history, social history. Maybe we should measure resilience in our families and see if resiliency scores can be increased. and really kind of working through a process with the families that we treat, not doing this patriarchal care where we simply quickly tell them what to do and get them out the door, but working kind of through a process of problem solving, either directly as caregivers or through our integrated services. So overall, there's conclusive evidence trauma is linked to illness. Resilience is linked to healthy adaptation, that we can define resilience, we can measure resilience, and maybe we should invest in building resilience. So with that, I welcome questions and thank you. Yes. Yes. I did not come across any that looks at just school environment. Many of those multidimensional measures of resilience does ask about resiliency or the school environment and how the school contributes to resiliency, but none that look just at school environments. And I looked at a lot of research. I'm not sure. Maybe that's a potential area. Yeah. Any other questions? Dr. Dooley?
Thanks, Nora.
Sure.
For presenting this really important information. I know that you've done a lot of work and you mentioned it with the National Survey of Children's Health and the measures that they use to look at resilience. The survey also has measures of flourishing.
Yes.
And I wonder whether you thought about looking at any relationship between resilience and flourishing.
So that has been done. I chose not to because I kind of wanted to focus a little bit more on family and community in terms of a perhaps something that I felt that I could influence more than just kind of those individual relationship skills. But I know that research has been done looking at individual flourishing and health outcomes. Yeah. Yes?
Well, can you repeat the question so those folks?
Oh, sure, absolutely.
So looking at the foster care studies, the one mentioned that children in foster care who went back to their families of origin had some of the worst responses to stress as opposed to families who were more permanently placed in a positive foster environment.
Mm-hmm.
I know one of the main goals of foster care is reunification.
Mm-hmm.
When appropriate. How do you think this kind of information should influence that goal?
So the question is looking back at the that study that showed that children that remain with their families of origin as they work through adversity versus families that are put in the foster care system and the ones that, and looking at the cortisol responses. I'm glad you asked that question because as I'm presenting that research, it gave me pause because overall, the goal is reunification because long-term health outcomes is better for children that are reunified versus non-reunified. And I really think it has to do with what that study doesn't look at is ultimately how the family works through the problem, how working through that problem to achieve a healthy outcome for those families that succeed. And we know families that succeed, it's really about overcoming the problem and staying in a healthy place. And maybe resilience is built in those children that see their families work through those problems better. What we do know is that children that go in and out of foster care as the families relapse into difficulties have the absolute worst health outcomes. So maybe those families aren't working through any problem at all, and resilience isn't being built. I think that study, although it's very interesting in that it shows that kind of healthier cortisol release pattern in children, the ones that are removed from the adversity, I don't think it shows the whole picture. And so I'm glad you asked that question because it allows me to say that. I didn't plant you though. Yes.
Angela on the chat line asked, what is one thing you could do during a primary care visit that would start the conversation about resilience with
I think it's about how we address problems, which is, I think it's about like, what have you tried to do? What have you, so really kind of encouraging a dialogue with a problem. So, everything from, in an asthma exacerbation, well, what do you do first? What do you do next? And so kind of recognizing that they can work through a problem. And I think that's more of a process response, is what's the process that we use with families? And kind of opening a dialogue and having that kind of mutual problem-solving approach. And sometimes that's best. Yeah. Hi, Zanar. Thank you. Yeah.
So thinking of literally and figuratively of a neighborhood makes me think more about the community input and the effect that has when you think of accessibility, right?
Yes, yes.
Of the other resources and the other possibilities or opportunities for other community members to help and step in and with that resilience factor. Think of like a coach or a community center coach who helps bring, if it wasn't for this coach, I wouldn't have made it.
Exactly. Oh, yeah.
Success stories that you think about when they're having a score through the roof.
Yep.
They have somebody, another protective factor there. So I wonder, it makes me wonder if how, or if you thought about how other factors are playing into not just with the family, the immediate family home, but within that community neighborhood.
Yeah, so Zanar just asked about the question about how community resilience and how like people out in the community, like that one coach that kind of, the example is if it weren't for this coach, how that can kind of change things for a child. And there's definitely been the studies that look at community resilience and health outcomes and how community resilience kind of buffers the effect of adversities and those negative health outcomes that occur. And I would be, I didn't see any. What I'd like to see if I could is a study that kind of comes in with a concerted effort to build community resilience and seeing if we can drop some of the rates of illness by kind of building resilience, like can building resilience in a community decrease health outcomes. So really we're not treating, in addition to treating the individual, but treating a community. And sometimes I think we're losing that in our world of it takes a village, of neighbors knowing each other, neighbors helping each other out, having the child whose parents have substance abuse problems, mental health problems, but they know they can go to their neighbor's house, and at their neighbor's house they'll be fed, they'll be loved, they'll be cared for, and they kind of get through that a lot less traumatically because there is a community that looks out for the child. So, I mean, I would love to see a community study. I think that would take a big NIH grant, and maybe in 10 years, maybe 5 years, why not? Anybody else? All right, well, thank you all, and I hope you all go build resilience.